For the next talk on PET-CT imaging in hematological malignancies, may I please call upon Dr. Riffat Hussain. Dr. Riffat holds a master's degree in nuclear medicine and in health profession education. She holds fellowship of Asian Mode of Nuclear Medicine. She has contributed immensely in medical education. She has numerous publications to her credit. And she is currently working as consultant nuclear physician at PET-CT facility at Department of Radiation Oncology, JPMC.
Okay, my presentation today is on PET-CT imaging in hematological malignancy. We'll try to cover within time, hopefully. But it's a long topic, yes. So the order of discussion will be that I will be discussing the hematological malignancies, the FDG in hematological malignancies, which includes the uptake, staging, response to treatments, the follow-up, and some advances, neuroimaging agents, and future prospects. So first of all, the hematological malignancies, we all know that they are the cancers. The cancer is of three main types: lymphomas, leukemias, and myeloma, and they're divided based on the cell of origin from where they are diagnosed at the time of origin. Lymphoma, which starts in the lymph nodes, leukemia in the blood, and myeloma in the bones. So the hematological malignancies, we have a long list of hematological malignancies in which we have the myeloid disorders, which include the acute and the chronic leukemias, the lymphoid disorders, which has the lymphomas, the major of which are the Hodgkin's and the non-Hodgkin's, and then finally the plasma cell myeloma. Because lymphoma has the greatest, PET-CT has the greatest gift to the lymphomas, we will be discussing these in a bit more detail. So first and foremost, lymphomas, these are the Hodgkin's and the non-Hodgkin's lymphoma. This is how they may be divided, but I like to divide them, the Hodgkin lymphoma, into the classical and the nodular lymphocyte predominant, because the classical is primarily of 95%. It includes the nodular sclerosis, the mixed cellularity, and the lymphocyte rich or the depleted. Now, the prognosis is related to the stage of the disease and the presence of the systematic symptoms. 60 to 30% of these occur in the lymph nodes, but extranodal have been reported. The spread is direct, and hematogenesis can occur, which is 10 to 15% of the cases, and if that so happens, then that's a poor prognosis. So the non-Hodgkin lymphomas has the three main types, but within these there is many subdivisions which you can see. But the more important ones are the ones which have been highlighted, which include the DLBCL, the follicular lymphomas, the Burkitt's, the adult T-cell leukemia or the lymphomas, and the mycosis fungoides. Another way that I'd like to divide this is based upon their aggressiveness, which helps in the reporting of these cases. The aggressive are 60%, which include mostly the DLBCLs, which can be nodal, extranodal, or both, treated with chemotherapy and radiotherapy. And the best thing about them is that 85% of them are mostly cured. The indolent ones are the 40%, of which the follicular lymphomas is about 22%. It has the translocation of the gene 14 to 18. And they have a 5 to 7 annual rate of transformation to DLBCL. Extranodal can happen to the bone and liver, and bone and liver extranodal involvement is commonly encountered. Both the Hodgkin's and the non-Hodgkin lymphomas are generally very FDG avid. Some are some of the non-Hodgkin lymphomas do have questionable uptakes, such as the mantle cell and others, but FDGs do help in the diagnosis and further treatment management in these cases too. So the optimal management of the lymphoma requires the interpreting nuclear physician or the radiologist to be familiar with a few things, which includes these types of lymphomas that I have discussed, the natural course of the diseases, whether they're aggressive, they're not aggressive, whether they're indolent, whether they will take up the FDG or not. There are treatment options that are available so that when you are reporting the interim scans, that helps in providing useful information to the referring physicians, and when to scan these patients and what exactly to see. So now the applications for the FDG PET is staging, of course, staging and restaging. That is, you stage before any treatment is started, and this is important because any dose of chemo may decrease the uptake, causing an underestimation of the stage. To monitor response to therapy, predict the outcomes, differentiate scar from the residual tumors, and assessment for tumor recurrence. Now, the staging was done previously with ultrasound, which has become almost obsolete, with CT, which has a high sensitivity and specificity in the pre-treatment staging, but low evaluation in the treatment response. MRI, the sensitivity and specificity is the same as for CT, and for bone marrow estimation, that is best. And then there is FDG PET. So the staging system of the Ann Arbor, which was introduced in 1971 and was progressively improved upon with the Cotswold and the modified Cotswold, is the landmark staging classification and simply anatomic. And the stage 1, as you can see, involves lymph nodes to one side of the body, above or below the diaphragm. Stage 2, nodal stations, which may be above or below the diaphragm. Then stage 3, where you cross the diaphragm, and then stage 4, where there is a widespread disease to multiple organs. Of course, there are other additional substaging variables that are considered with this Ann Arbor staging system. Now, with the Lugano this was introduced in 2014. And it was based on the use of FDG PET because this was primarily metabolic imaging. Now it is used widely in daily clinical oncological practices. It has the advantage of being sensitive and specific for identifying nodal or extranodal lesions, which may be missed by the conventional staging methods, including CT. And then improving the characterization of the lesions, which may be equivocal with other types of imaging. Now, with the revised staging system of Lugano, this is how it is staged, which primarily follows the same as in and the Ann Arbor classification, except for the fact that here we identify the nodes or the tissues based upon the uptake of the radio tracer. So. This was pretty simple that I just gave to you, but when you are reporting with this classification, it has so much more to take into account than just that simple chart that I put up there. So bringing them both together, so stage 1 for Ann Arbor, and then you have stage 1 for the FDG. Stage 2, both sides of the body, on both sides above the diaphragm. Stage 3, where you have a crossing over below the diaphragm in the spleen, not in the spleen, which is a nodal tissue, and the nodes in the gastrosplenic ligament. And then stage 4, where you have extranodal involvements. This is extensive to the bone. This is again into the lung, and then miliary. So now the response assessment in the lymphomas. So firstly, there is, you have to do a baseline scan to the stages that I showed, and then when there is an institution of therapy, FDG is a sensitive biological marker for chemosensitivity and early response treatment, and presents as a decrease in tumoral FDG uptake. The decrease in uptake is from the chemotherapy directed to the tumor killing cells, killing the tumor cells and inhibiting the growth and proliferation within hours to days. It is primarily done at 2 points in time, the interim imaging and the end of treatment. The interim PET scan, if it is negative after a few cycles and tumor killing rate is sufficiently high and will achieve a likely remission by 6 to 8 cycles. And if it is positive, then this indicates that a fewer than 2 to 3 log unit of tumor cells have been killed, and remission unlikely by the end of treatment. And now there has to be a change in management, or maybe chemotherapy or whatever should be undertaken. Now this interim PET scan has now been recommended as a standard of care by the 2020 NCCN guidelines that have been put in place, right? So interim PET scans, this is used to monitor patients as early as 1 to 3 cycles of chemotherapy, provides insight about the level of chemosensitivity, has demonstrated promising results in predicting final response, as I discussed earlier, and it may enable de-escalation of chemotherapy where we see a response in the chemotherapy, hence sparing the patients with the toxicity of chemo and other issues, and then maybe a treatment escalation where we see that there is not an adequate response to the chemotherapy therapy that is being given. The end of treatment scan, the imaging modality of choice for end of treatment for response evaluation at the end of induction therapy, especially useful for patients with high tumor burden who may require immunotherapy later, and sets an endpoint from which further management is assessed, whether we want to take a further treatment, enhance, or give additional therapy, or perhaps may even change the treatment. So what is the standard or the point of evaluation or the scoring standard against which these scans are to be evaluated? So this is the Deauville score, which was developed by St. Thomas and Guy's Hospital. And this is based upon the visual imaging of the tumors and then the uptake of the tumors. And then we have the various responses, which may be a complete metabolic response with or without residual masses, partial metabolic response, no metabolic response, or a progressive disease. So let's look at some of the response treatment scans. Complete metabolic response. So this was a baseline scan and the end of treatment scan where we see a complete resolution of the previously seen tumors with the high uptake of the radiotracer. Partial metabolic response. Here we have a baseline scan where we see a large tumor load. And then later, after 6 cycles, we see a significant reduction, but however, still some tumor cells that are, tissues that are still there, and hence here at this point, a change in chemotherapy perhaps, or a change of regimen altogether should be taken into consideration. Progression of disease, initial scan, and a rescan. Initial scan, this was interim scan where we saw a good resolution, and then after some months we see a complete alteration of this. So leukemias and multiple myelomas. Firstly, leukemias, we saw here the myeloid disorders, which were the acute and the chronic leukemic diseases. So the chronic lymphocytic leukemia is most common in the elderly, whereas the acute lymphoblastic leukemia is most common in the pediatric population. And then in addition to this, there are some other cell types which are also studied. So for the leukemias, PET-CT is generally not used because it does not present as a solid tumor. Bone marrow examination remains the gold standard for its diagnosis. Recent studies, however, have shown that PET-CT has a role to play in the non-invasive diagnosis and treatment of leukemias, may present as a diffuse uptake in the body or in the bone marrow, and then there may be focal uptakes within the bone marrow and outside the bone marrow, which are the extramedullary lesions. It may help in the early diagnosis of patients presenting with no remarkable abnormality of the peripheral blood film and non-specific symptoms of bone pain and fever, where we may be able to show the lesions, focal lesions in the bone marrow, or even the extramedullary regions. Now, the extramedullary lesion refers to lesions that occur in the anatomical site outside the bone marrow. In the treatment evaluation, it has an important and definite role to play, follows the same methods and standards that we have adopted for lymphomas, where we have a baseline scan, an interim scan, and end of treatment scan. So this is for the leukemic diagnosis, where you can see that we have, do we have a pointer? These lesions here and in the liver and elsewhere, and especially here in the pelvis, right over here. So here is another scan. Sorry, where did it go? So So this is another scan where this is a treatment scan where initial scan was this, and oops, where are we going? So this was the initial scan, and treatment was instituted, but the patient came back with bone pains and this mass in the lungs and everything. And then when we did a scan, there was a whole different picture that came out here. And then another one. And this was a treatment response, partial treatment here. We don't have the initial scan for this. There was a partial treatment to the chemotherapy. And then later, we saw that there is a, here, if you see, this is the partial treatment. And then later, this was in January when the chemo was completed. And then we had later, whole of the tumor came right back. So then all is not gone. Sometimes we had some very good scans too, where we have some stable leukemic disease, and over a long period of time, we do get to see very good scans too. So this was a scan where we saw that this was. So FTG has a very significant role to play in the Richter syndrome, which is a chronic lymphocytic leukemia converting into the DLBCL, which is usually very malignant. And it carries a poor prognosis, and the median survival is 5 to 8 months, and prompt diagnosis is very necessary. Now, the thing about this is that the clinical features are very non-specific, and the patients complain of fever and enlarging lymph nodes, which they don't suspect to be of great significance. However, that may be the first telling sign of this conversion, and then elevated lactate dehydrogenase. Now, if the patients complain of CLL, complain of lymph nodes, and these should be followed with the FTG PET as a surveillance tool to counteract these. Then FTG PET CT also has a role to play in the graft versus host disease for the allo hematopoietic stem cell transfusions. Transplantations, and this is because this is a very important variety. It is the only cure for the most malignant blood diseases, and it is limited by immunological recognition and destruction of the host tissue, primary cause of death after these autologous transplantations. It has a predilection for certain organs, which include the epithelial surface of the skins and the mucous membrane and the biliary ducts of the liver and the crypts of the gastrointestinal tract. Now, the clinical labs and histology may help in the early diagnosis of the skin and the liver, but the GIT are the difficult ones to diagnose. Unfortunately, we have not encountered any of these. Otherwise, I would have showed you some pictures of these also, but they exist, and we should keep them in mind. Okay, so of course, PET CT, when done, can actually look at the GIT uptakes in these conditions. So what is the future trends? The future trends are these new traces, which are there, and perhaps in the future we may see them coming in. And then what next? Artificial intelligence is there, which we all talked about, and then immunopet also, which again has a load of other traces which can be read up. Now, multiple myeloma. Multiple myeloma is the second most common hematological malignancy, and it is characterized by the proliferation of the plasma cells producing a monoclonal immunoglobulins. It is diagnosed with labs which have anemia, hypercalcemia, renal failure imaging, lytic bone disease, whole body X-ray CTs and MRIs, and of course in PET CT. Then medullary, in the marrow, there's a medullary and the extramedullary, which is very important in terms of prognosis of this disease. It was previously assessed by radiographs, bone destruction of 50 to 75% of which was required to see them. Then international guidelines recommended CT, whole body MRI, and FTG PET. MRI is excellent but difficult in differentiating between residual disease and actual disease after treatment. The paramedullary and the extramedullary appearance of these myelomas is very important, and like I said, they have a bad prognostic relation and should be identified, and the only way to identify them is by scanning the whole body, in which the PET-CT has a major role to play. So it has a PET-CT in multiple myeloma has yielded promising results in diagnosing, staging, and managing of the multiple myelomas. Like I said, it has the ability to distinguish the intramedullary and the extramedullary lesions. Most useful advantage is the assessment of therapy response, and it is best performed at baseline and after neoadjuvant therapy before stem cell transplantation. Presence of more than 3 FDG avid focal lesion at baseline was an independent parameter associated with the inferior overall and event-free survival. Evidence supports focal lesion as origins of resistant disease and have a negative prognostic effect. And then, of course, follow-up, like I said earlier, for the leukemias. We can also follow up for the multiple myelomas also. So some cases from the multiple myelomas, this patient came with a swelling of the right side of the mandible, which we can see here. And when we scanned this patient, we saw in the cranium, in the maxillary sinus, and in the sternum. So multiple lesions were identified. Similarly, this was another case in which we had a raindrop appearance of the skull with multiple lytic lesions, which I hope you can see here, which were FDG avid. And then when we scanned the whole body, we saw in the scapula, the left scapula, the SI joint, and this sacrum. So the neotraces for multiple myeloma, they are also under development, and small data on therapy and assessment and prognosis is available. Tracers that are have been identified are these that are given here. And of course, there's also the immunopet agents which are coming up. So lastly, I would just like to talk about the metabolic tumor volume and the total lesion glycolysis, which has been talked about a lot, reported a lot, and is being researched a lot. But as we were discussing at the beginning of the session, it's all about artificial intelligence and radionomics. And of course, even at our center, we are studying the metabolic tumor volumes in the pediatric population, and we hope to report those findings. But it's just that it is a very tedious task, and it is highly operator dependent and requires a person who is well versed with drawing the lesions and giving these results. Artificial intelligence, we hope, will take over, and then, as said, the radionomics, which is a mathematical evaluation of these lesions, will help us in delineating these lesions and then following them over time. And then there is also the total lesion glycolysis, which is the metabolic tumor volume multiplied by the SUV mean of the lesion, which also can predict the outcome of the tumor and the possibility of the possible result of the treatment that is being given. However, at present, we do not have any results to give to you. However, this is there in the literature, and I'm sure you all can read up and see what this is. Right? Thank you.